Protocol 19, the cold exposure protocol. In this protocol, we just want to remind you that no patient is dead until warm and dead. Hypothermia is defined. The parameters are 35 degrees Celsius or 95 degrees Fahrenheit. And hypothermia may produce severe bradycardia. So we need to remember to take as much as 45 seconds to palpate a pulse. And don't forget, use hot packs to warm your patients up. We want to consider withholding CPR if the patient has an organized rhythm or has other signs of life, and we can determine this when further care arrives. If the patient's temperature is less than 30 degrees Celsius or 86 degrees Fahrenheit, we only shock or defibrillate one time and then continue with our care. Protocol 20 is the heat exposure heat stroke protocol in the environmental emergencies section. Protocol 20 is a really great reference for our providers. It really separates heat cramps, heat exhaustion, and heat stroke. For our advanced providers, for anything above heat cramps, so heat exhaustion and heat stroke, we want them to administer a bolus of 500 milliliters and repeat to a max of 2 liters. They need to maintain a systolic blood pressure greater than 90 millimeters of mercury. Certain individuals who are predisposed to heat emergencies by prescription medications are tricyclic antidepressant patients, phenothiazine patients, anticholinergic medications, and alcohol, cocaine abuse, and salicylate and amphetamine abuse. Sweating generally disappears at 104 degrees Fahrenheit. And just a reminder, that is the same parameter as a fever, but of course our fevers are only treated when they are the result of a medical condition, not an environmental emergency. So in heat exposure and heat stroke, just some notes here. Heat cramps are not associated with elevated body temperature. However, heat exhaustion vitals consist of tachycardia, hypotension, and elevated body temperature, and heat stroke vitals consist of tachycardia, hypotension, and of course a temperature greater than 104 degrees Fahrenheit with altered mental status. Protocol 21 is our bites and envenomations on land protocol. This protocol covers snake bites, spider bites, bees and wasp stings, and dog, cat, and human bites. Very general care within this protocol, no real change from your current protocols. Protocol 22 is our burns protocol, and it separates burns, or the treatment of burn emergencies, into 3 categories: minor burns, serious burns, and critical burns. For our advanced providers in serious and critical burns, we want to establish an IV. We need to consider 2 lines in this case because we're going to need to administer a lot of fluid to this patient. Of course, 0.25 milliliters per kilogram times the total body surface area burned percentage per hour for the first 8 hours. What this is a Parkland formula. They've just done half the math for you. So an example below, you have a 220-pound patient. That's 100 kilograms. He has 18% of his total body surface area burned. So 0.25 times 100 equals 25, times 18% equals 450 milliliters an hour. Okay, so just some things to remember when treating your burn patients. These patients listed below need direct transport to a burn center or transfer once seen at a local facility if that patient needs to be stabilized. Patients with greater than 5 to 15% total body surface area second or third degree burns, greater than 5% total body surface area third degree burns for any age group, any patient with circumferential burns, patients who have electrical or lightning burns, suspicion of abuse or neglect, any inhalation burns, chemical burns, and burns to face, hands, feet, or perineum or genitalia. Okay, just remember that our burn patients are prone to hypothermia. We never administer any IM medications to burn patient. We want to assure proper decontamination of all patient providers and equipment, and contact the receiving facility as soon as possible. Your burn centers listed below are VCU in Richmond, Virginia. That's an adult and pediatric burn center. Washington Hospital Center in Washington, D.C. is an adult-only burn center. North Carolina JC Medical Center in Chapel Hill, North Carolina is adult and pediatric, and Johns Hopkins Regional Burn Center is adult only in Baltimore, Maryland. And Wake Forest University Baptist Medical Center in Winston-Salem, North Carolina is adults and pediatric burn center. And of course, because of the distance of these burn centers, we want to consider air medical transport. Protocol 23 is a carbon monoxide smoke inhalation protocol. No change in treatment from your current protocols. However, this is a new protocol to you as a provider within Fauquier County. We want to consider CO and cyanide with any products of combustion. So any victims of structure fire or car fire, anybody who's exposed to any smoke, we want to consider CO poisoning and now cyanide poisoning as well. Continue high flow oxygen regardless of pulse oximetry readings on these patients, and obviously consider ALS. We do have an antidote now at the ALS level for cyanide exposure. Protocol 24 is our crush syndrome protocol. And for our advanced providers in crush syndrome, it is very heavily fluid resuscitation based. Normal saline boluses of 1 liter. Consider a second line and an additional liter if the patient has been trapped for greater than 1 hour. Of course, while doing this, you need to assess for fluid overload. Protocol 25 is our extremity injury protocol, and again, no real change from your current protocol.